So chapter 17, digestive system. And we are going to do a little bit of A and P because you can be asked about it. Some stuff that's related as usual. So digestive system, basically you ingest the food, you digest the food, and you absorb the food. These are the basics. And we have the digestive system start from here, from the mouth, going to the oropharynx, esophagus, stomach, small intestine, large intestine. Small intestine is duodenum, jejunum, and ileum. Large intestine starts from here, which is called the cecum, ascending colon, transverse, descending sigmoid, rectum, and anus. This is generally speaking the digestive tract. There are appendages, other organs that are appended to that tract, which are pancreas, liver, and gallbladder. This is just generally speaking. This is the wall, start from the mucosa, going all the way to the serosa. We have the oral cavity, pharynx, esophagus, and so on. You put the food in your mouth, and you start to do some chemical digestion, which is salivary amylase and lingual lipase. And this is something that you need to know. You need to remember this. So beside putting the food in our mouth and we mechanically break it down with the teeth, do we do some digestion? A little bit of digestion, a little bit, which is salivary amylase and lingual lipase. So we basically start the digestion of carbohydrates and lipids a little bit. And then you push the food backwards to go to your pharynx and go to the esophagus, which is called swallowing or deglutition. And this process needs a coordination of these nerves, 5, 9, 10, and 12. Okay? I'm focusing on certain parts that are related, so you need to know this. Swallowing in the pharynx, push the food backward. This needs a lot of coordination because you want to push the food backward. You don't want to go up to the nose or down to your airways, right? You need a lot of coordination. Coordination between 5, 9, 10, and 12. And then the food will go down the esophagus until it reaches the stomach. Now, stomach, what's the function of the stomach? Number one, storage, temporary storage. You temporarily store the food from 2 to 6 hours, depending on what kind of food are you eating, right? If you're eating simple food, something like carbohydrates or something, it will not take that much time. If you're eating something like fat or proteins, that will take longer time. It will stay more. So it's temporary storage, that's number one. Number two, mixing and mechanical digestion as well, which is the muscles contract in different directions in order to break down the food further. And it's going to mix it with, this is very important to remember. You have to remember this. It's going to do the following. Number one, storage. Number two, more mechanical digestion and mixing. Number three is the most important, which is the chemical digestion. Chemical digestion. What exactly is going to happen here? Your stomach is going to release pepsin. And this pepsin is secreted in the form of pepsinogen. Remember, gen is a suffix at the end of any word. Any word, you put gen at the end, it means it's a precursor of, or it's an inactive form of. So pepsinogen means an inactive form of pepsin. Just remove the gen, okay? So pepsinogen, everything, all enzymes are secreted in an inactive form. If it is secreted active, it will break down the organ that produces it. Know what I mean? So the stomach produces it. If it is pepsin, it's going to digest the stomach itself. You don't do that. You produce it in the form of inactive form, which is pepsinogen. And pepsinogen, after being released in active, the stomach is going to also secrete HCl, hydrochloric acid. And this hydrochloric acid is what's going to activate pepsinogen to become pepsin. And what's the pepsin? This is the first proteolytic enzyme. This is the first enzyme that's going to break down proteins. Okay? What else are we going to do in the stomach? Intrinsic factor. And this is important. Intrinsic factor. What's intrinsic factor? The intrinsic factor is a factor that's released from the stomach to facilitate the absorption of vitamin B12. Meaning, you can eat as much as you want of vitamin B12 and you absorb nothing. You don't absorb anything because you don't have intrinsic factor. Here is what I mean by that. What if this is a person who cut his stomach for some reason? He had a tumor, he needed surgery, whatever the reason is, and he cut his stomach. What's going to happen? No vitamin B12 absorption. How about I increase, I eat more, double, triple? It doesn't matter. You're not going to absorb it anyway because of the intrinsic factor. Okay? Those people who need to lose weight, they are supposed to cut a good part of the stomach. Some of the surgeries, not the only one surgery, there is a lab ban, but some of the surgeries for morbid obesity, they can cut the stomach itself. They are not supposed to cut the cells that produce intrinsic factor. What if it happened? What if the stomach is destroyed for any reason? No intrinsic factor, no absorption of vitamin B12, pernicious anemia. Pernicious anemia. Intrinsic factor for vitamin B12. Okay? After doing all of that, so the food go from the esophagus, go to the stomach. Temporary storage, mechanical digestion, add hydrochloric acid, add pepsinogen that will become pepsin, add intrinsic factor. All of this together will become a paste-like product that's going to leave the stomach, and you call this the chyme. Okay? So what you swallow is called the bolus of food. Let's say you have food in your mouth, chew it, break it down, swallow. You're swallowing a bolus, which is egg-like, bolus, semi-solid. But when it leaves the stomach, it's not the case anymore. It will become more like a paste. And this is called the chyme. Liver. This is the next organ. And the liver is called the metabolic factory of the body. Why? Because when you eat, you absorb from your small intestine mainly, not only the small intestine, mainly. You have some absorption from the large intestine and a little bit from the stomach. But where is the vast majority of absorption? Small intestine. Be more specific. Ileum, followed by jejunum. Is that the only region? No. I'm saying the most. And remember, it makes a huge difference. It makes a difference. What's the most common? What's the most important? Okay, where does the majority occur? It matters. Don't just tell me it's from the stomach, small intestine, large intestine. That's not enough. Okay? So you need to know that specifically. The liver, why did you call it the metabolic factory? Basically, when you eat the food, it goes to your stomach, intestine, and so on, and you absorb. When you absorb, the food go to the blood. We all know that. Absorption is the food, the smallest molecules, the smallest components of food cross the wall and go to the blood. Do we know that? This is absorption, right? Which blood? Which blood? The blood of the hepatic portal vein, specifically. Hepatic portal vein. And hepatic portal vein is going to go like this. From the digestive tract, everything that's absorbed, go to the blood, it will take it all the way to the liver. That's it. This is a special circuit, a special circulation. It's a closed circuit. Just from the digestive tract to the liver, that's it. Hepatic portal system. And this blood is deoxygenated because it's coming from the digestive tract. It's not coming from the heart. Deoxygenated. However, if you remember in A&P, the liver is also receiving arterial blood through the hepatic artery, which is oxygenated. So obviously the liver is receiving both. Oxygenated and deoxygenated, both of them. The liver is the only one organ that receives both of those. For the digestive tract. So it will receive both of them, oxygenated to feed the liver, deoxygenated, and this is carrying the nutrients that's newly absorbed from the digestive tract to the liver. The liver will take care of it. Okay? And what do we mean by taking care of it? This is the metabolic factory. Here is the liver. We'll say, okay, so you eat, you absorb, the food come to me. The food is, when I say food, nutrients, it has to be in the smallest molecules, like Protein will become amino acid. Carbohydrate will become monosaccharides. Fat will become fatty acids. Are we all following so far? Are we following? This is what you absorb. You absorb the smallest molecule of all. Protein, amino acid, fat, fatty acid, carbohydrates, monosaccharides. This is all absorbed. Go to the hepatic portal vein and go to the liver, and liver will take it from there and will say, okay, let me see what we got here. You got a lot of carbohydrates. This is beyond your needs. I'll give you some and I will store the remaining part. How are you going to store it? In the form of glycogen. Glycogen. So the excess, and you always eat more than you need. This is always the case. Unless you're eating something like this. You always eat more than what you need. So the liver will say, okay, let me see, carbohydrate, this is a lot. I'll give you some and I will keep the rest. Store it in the form of glycogen. You call this process, you converted glucose to glycogen, right? Glycogenesis. Okay? Glycogenesis. What genesis means? Generation, formation, making, right? So glycogen genesis, generating glycogen. Does the name give it away, if you understand it? The name give it away. Glycogen genesis. So this is the first process. You're converting the glucose that's absorbed. Go to the liver, this is a lot. I'm going to store part of it in the form of glycogen. Glycogenesis, okay? So this is one thing. How about proteins? It depends on your needs. I can give you some, store some. How about vitamins? 90-something% of the time you take more than your needs. It will be stored. Minerals, stored. Okay? How about some toxins? Toxins. Deactivated, right? You can get some toxins from the products of the food, or the food was not clear, or whatever the reason is, it's going to deactivate, detoxify the toxins, right? So it's taking care of the food in general. And I mentioned it here, glycogenesis, and it's going to do some protein and fat metabolism, storing the excess and so on. The other thing is it's going to produce plasma proteins. Plasma proteins. The plasma proteins, which is albumin, fibrinogen, globulin, all of this is plasma proteins. We make it in the liver. The other thing is bile. Where do we make the bile? We make it in the liver. What's the function of the bile? Does anybody remember the function of the bile? It's important for digestion of what? Carbohydrates or fats or proteins?
Protein.
Fat. 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 It emulsifies the fat. What's emulsify the fat? Emulsification means, you will see. Emulsification means you break it down into smaller molecules. And let me give you a practical example. Do you wash your dishes? Right? When you wash your dishes, don't you add something first, like detergent or whatever you're using, right? If you try without this, you can't take the fat out of the plates, right? You have to add this and wash it and it will go away, right? This is emulsification. You're emulsifying the fat in your plate. What does it mean? It means you have bulks of fat, and when you add this, you're going to break it down into smaller, very small pieces, and then you can wash it with the water. This is emulsification, and that's what you're doing inside your body. So plasma proteins. The other thing is the old red blood cells. The old red blood cells, after 120 days, which is the lifespan of the red blood cells, it goes to the liver and the spleen as well. And you break it down into the smallest molecules, and then you're going to recycle a good part of it, which is mainly iron and amino acids. And you send those two back to the bone marrow to reproduce. You're recycling most of it. How about the remnants, the remaining part? Not needed. You need to get rid of it. You change it into bilirubin. And this will make a lot of sense later on. Are we following so far with the functions of the liver? Mm-hmm. How about the pancreas? Let me say something general to cover all of this. Pancreas. Two things. Exocrine and endocrine functions. Exo and endo. Exo and endo. Exo is the pancreatic juice. Endo, hormones, insulin and glucagon. Exo, pancreatic juice. Let me put everything together just to make it in two categories. Enzymes and bicarb. Enzymes, bicarb. Enzymes, bicarb. What kind of enzymes? Enzymes that break down everything. Everything. Remember when I started, I said in the mouth, you have lingual lipase, salivary amylase, so this is you're breaking down fat, you're breaking down some carbohydrates, and then in the stomach we say pepsin, right? So each organ will break down something, not the pancreas. The pancreas releases enzymes for everything. Everything, literally. You release enzymes for carbohydrate, fat, protein, nucleic acid, everything. Everything. But specifically trypsin is something for the proteins. It's an enzyme to break down protein. And this will be the second enzyme that we talked about. Remember pepsin in the stomach? Proteolytic. Trypsin in the pancreas is proteolytic. And the other one is bicarb. So what's the exocrine function? Pancreatic juice. What's the pancreatic juice? Generally speaking, two things. Enzymes and bicarb. Bicarb. Enzymes and bicarb. Enzymes for what? For everything. Most importantly, trypsin for protein, but you break down everything. Have amylase, peptidase, everything, everything. But trypsin is a proteolytic enzyme, which is a lot more important. And bicarb. And why are you producing bicarb in the pancreas? Because the pancreas open to the duodenum, which is the first part of the small intestine. Remember that you produce hydrochloric acid in your stomach? We all know that, right? So the chyme, as it is leaving the stomach, it's very acidic. Very acidic. And the stomach is okay with that, because the stomach is prepared. The inside of the stomach, which is the mucous membrane inside, is prepared. Okay? To take care of this acidity. Duodenum, it is prepared, not as much. And the rest of the small intestine, not as much. So as it leaves from the stomach, go to the duodenum, you pour in a lot of bicarb that's coming from the pancreas to neutralize the high acidity that's coming from the stomach. Did we get this part? Okay. Then you have the small intestine and large intestine. Small intestine, you have duodenum, jejunum, and ileum. And duodenum is the shortest of all. Most of the absorption happen in the ileum, followed by jejunum. Does it mean that you don't absorb from the duodenum? You do. Large intestine? Yes. But what's the most? Ileum, followed by jejunum. And inside the wall of the small intestine you have villi. Why do you have villi? To increase the surface area. So this is the small intestine like this, and this is the wall. The wall will have like this. Will have villi to increase the surface area for absorption. If that's not the case, if something happened, we will talk about the disease. If you break down these villi, you will not be able to absorb as much. Okay? And again, I'm only saying that what's relevant to this chapter. Okay? There are also lacteals, and these are small lymphatics that will take the lipids that's absorbed. Remember that proteins and carbohydrates, when you absorb, it go to the liver, not the lipids. The lipids go through lacteals. Okay? You also produce enzymes like enterokinase, peptidase, nuclease. It is for most of the nutrients to be digested. This is summarizing the action of all enzymes, but I focused on the most important of all. Now the large intestine. The large intestine is specifically important for the following. The bottom line. You make some vitamins and absorb it. Which vitamin? Vitamin K specifically. Vitamin K specifically. And vitamin K, you make it in the large intestine. How do you make it? Does anybody know? Bacteria. The good bacteria in your large intestine do it. So if you wipe off the bacteria, you think it's bad. It's not bad. It's good bacteria. Make vitamin K for you. And vitamin K is important for blood clot, specifically. So what do you do in the large intestine? Make and absorb some vitamins. Specifically, vitamin K is important. You reabsorb fluid and electrolytes, and you also reabsorb bile. So you make the bile in the liver, you store it in the gallbladder, it goes in the common bile duct to the duodenum, help you to emulsify the fat. Now we did the job. Should I throw it away? No. You can't afford to do that. Production of bile is kind of hard. So when it goes to the large intestine, it will be, good part of it will be recycled. You reabsorb. Are we good so far? Plus, of course, making the feces and the defecation, you get rid of it. Innervation of or control of the digestive system. There is a nervous control and endocrine control. The nervous control is in the form of sympathetic and parasympathetic, and let me summarize it as follows. And if you forgot it, just imagine what I'm talking about right now. You are in the middle of the fight. You are in the middle of the fight. What do you think is going to happen? You are in a fight. Heart rate increase, respiratory rate increase, right? Concentrate more, your eyes open, and you suppress anything that's not needed during the fight, right? This is not the time to produce enzymes. This is not the time to digest. This is not the time to secrete. This is not the time to make urine. This is not the time for the reproductive system to work. It's not the time, right? You are fully concentrating on what you're doing right now, and this is sympathetic. So what's the function of the sympathetic? It depends. Are you talking about cardiovascular system, the muscles, the brain, the heart, for example? This will all go up. Anything that's not needed will go down. Be more specific. What happened to the motility during sympathetic of the digestive tract? Is it become more motile or less? Remember that you suppress all functions. You suppress all functions of the digestive tract. What are the functions? Digestion, absorption, movement, everything. You suppress everything. This is not the time. You said movement. Okay, if the sympathetic increase the movement in your intestine, you will make more feces. You push forward, you make more feces, and in the middle of the fight, I need to go to the bathroom. I have to run to the bathroom. Just give me a minute, I'll be right back. Do you do that? Of course not. So you suppress. It's the opposite. You suppress. Just simply suppress everything. Suppress everything. Okay? So motility, decrease. Secretion, decrease. Everything, decrease. This is not the time. All right? How about the parasympathetic? Exactly the opposite. What's the situation for parasympathetic? Rest, digest, isn't it? Rest, digest. You're relaxing, sitting, you're resting, and this is the time to digest. So what happened is exactly the opposite. Did we imagine what happened in the sympathetic? What increase and what decrease? Reverse it. That will be the parasympathetic. So if I ask you the parasympathetic, what happened to the motility? Increase or decrease? Increase. What happened to the secretion? Digestion. Everything. Everything increase for the parasympathetic. Everything decrease for the sympathetic. Did you get this point? This will be important later on a lot. Very important. When you understand it, you don't have to repeat later on. Did you get this point? Sympathetic versus parasympathetic. Okay? It's more specifically to remember the vagus nerve. This is the main nerve for parasympathetic. Vagus nerve. Specifically, vagus nerve. For the parasympathetic, we're talking about the vagus nerve. How about the hormones? We're going to produce 1, 2, 3. This is not the only ones. But this is the most important, and this is what we have to know. What kind of hormones do we produce? And what are the cells that produce it? Are we following? The cells that produce it are called enteroendocrine cells. Entero means intestine. Endocrine, producing hormones. This is the name. What exactly do you produce? Gastrin, from the gastrin producing cells in the stomach. And this is produced by, when do you produce gastrin? The food in the stomach. Stimulate the production of gastrin. And what is the function of gastrin? increase secretion motility, and stimulate the secretion of hydrochloric acid. You have to know this. Abnormalities just would be exactly the opposite, okay? Or increased. So what's a gastrin? Gastrin is the hormone produced from the name. Gastrin, gastric, stomach, right? What's the function of gastrin? When do you produce it? When the food is in the stomach. What does it do? Stimulate motility, stimulate secretion because the food is here. This is the time, right? And increase gastric acid secretion. This is one. Number two is cholecystokinin. When I was in medical school, the name was a little bit larger than that, a lot larger. They call it cholecystokinin pancreozymin. And this was the longest word in medical school. This is half. Cholecystokinin pancreozymin. I like the older one better, but it's not used anymore because it's actually describing exactly what's happening from the name. Cholecystokinin. Chole means bile. Cyst, bladder. So this is a gallbladder. Kinin, kinetic, contraction. So what's the function from the name? Contraction of gallbladder, right? Cholecystokinin. Cholecyst is the gallbladder. Cholecyst, gallbladder. Kinin, kinetic, contraction. So this is the enzyme that's produced from the duodenum specifically. When the chyme leaves the stomach, go to the duodenum, cholecystokinin is secreted. And it goes to the gallbladder, contract. Why? Because you stored the bile that's reduced in the liver, you stored it in the gallbladder. Now, contract your gallbladder, pushing the bile to go to the duodenum to be mixed with the food to emulsify. Are we following so far? So this is cholecystokinin. The rest of the name is pancreozymin. Pancreo means pancreas. Zymin means enzyme. Because it also, besides going to the gallbladder to contract, it also go to the pancreas and push the pancreas to produce its enzymes. Two functions. It's not just a gallbladder. It works in the gallbladder and the pancreas, but they found it too long, so they abbreviated. But you still need to know that it works on both of them. Last one is secretin, and secretin, what you have to remember about secretin is promote the secretion of bicarb from the pancreas. Bicarb from the pancreas. Are we okay so far? Bicarb from the pancreas. So here, do you remember when I started? Can you tell me what is this? Pancreas is producing two main things. Bicarb and enzymes. Enzymes come from cholecystokinin. Cholecystokinin, pancreozymin is what stimulates the enzymes. And the other one is bicarb, right? Bicarb, secretin. You have to remember this. So the food is going to stay in the stomach for 2 to 6 hours. And when the food goes to the stomach, there is a reflex that's important to know. When the food leaves the stomach, which is a chyme now, right? And it goes to the intestine. The intestine is taking care of the food, digesting it, absorbing it, so it will tell the stomach, enough. Don't give me any more, right? I'm busy now. You already gave me the food, and I'm taking care of it. Stop giving me more. So it's going to suppress, inhibit the stomach. And this reflex is called enterogastric reflex. It's a reflex. Entero means? Huh? No, enter is. Entero means intestine. Gastric means stomach. So enterogastric means from the intestine to the stomach. From the intestine to the stomach. Simply, a reflex from the intestine go to the stomach. Stop. I have the food, I'm taking care of it. Stop. Inhibiting the stomach. Enterogastric reflex. We talked about these hormones. The only one that's added here is the histamine. Histamine is not even a hormone, but it increases the secretion of hydrochloric acid in the stomach. Did you get the function of each one of those? Did you understand this? It was in the table. Just I added the histamine. Histamine H goes with the H. Histamine, hydrochloric acid. Histamine, hydrochloric acid. Now when you digest, what are you going to break down? Break down everything. Carbohydrate will become, what's the building unit of carbohydrate? Carbohydrate. What kind of sugar? Monosaccharide. Yes, monosaccharide. Protein will become amino acid. Fat? Fatty acid. Yes. So you eat this bulk and you make it very small. And this is how small it will be. Okay? Now when you break down the lipids specifically, you need to emulsify it by bile. Let me ask you this question. What if you know a person who removed the gallbladder, which is called cholecystectomy? He's going to have trouble with what? Which type of food? Fat. Fat. Why? Because you store the bile in the gallbladder and you contract pushing it when the lipid is in the duodenum, right? Emulsify lipids. So what if you don't have it? You don't emulsify. It's simple, right? You don't emulsify lipid. So you cannot absorb as much. And those people, they will tell them, restrict the fat. Take the minimum. Should you take 0? You can't take 0. You need everything, no matter how much you think it's bad. Okay? Fat, bad. It's going to affect my heart, my blood vessels. No, you need it. You need everything. Okay? So if you don't have the gallbladder, you don't have the bile, do not emulsify the lipids. You cannot digest the lipids. Exactly, I'm going to wash my dishes, but I don't have any detergent. Is that easy? Is that easy to do? Of course not, right? You have to add something. In order to emulsify the fat, meaning make it smaller molecules, and then use a sponge or something and to wash it, right? So you need that to work on the fat. And when you absorb the fat, it will be mixed fat. Fat does not dissolve in the water, right? And the blood is 2 components, plasma and cells, right? The plasma is mainly water. Do you know that? The fluid compartment, or the fluid part of the blood is mainly water. So if you take the fat, go to the blood, it doesn't work. It doesn't work. It will not be carried. So you need to mix it with something in order to be able to carry it in the blood. What's that something? It's proteins. So you get the fat coated with proteins so that it can be transferred in the blood. What do you call it? Chylomicron. Chylomicron. And this will be the first lipoprotein to talk about. Lipoprotein, lipid and protein. You absorb the lipid, coat it with proteins so that you can carry it in the blood. Are we okay so far? Okay. Now the vitamins. Vitamins, we have different types of vitamins. Some of them are fat soluble, which is A, D, E, K. And others are water soluble, which is B, C. B, there are a lot of B. Okay, 1, 2, 3, 6, 8, 12, 9, 12. There are a lot of vitamin Bs, but which is fat soluble and which is water soluble? Okay, you also absorb nutrients and drugs will be detoxified in the liver. You also absorb water and you reabsorb it in the large intestine. So you reabsorb water in the small intestine and then in the large intestine. Now the digestive disorders. Anorexia, nausea, vomiting, and bulimia. What each one of those means. Simply, anorexia, I don't want to eat. I don't feel like eating. I don't have an appetite. Loss of appetite. Nausea is I feel like I'm going to vomit. Okay? I'm going to throw up. I'm going to vomit. I'm going to. I didn't vomit. I feel like. Okay? Vomiting is the actual ejection of the food from the stomach going out. This is vomiting. Bulimia is something completely different. Bulimia nervosa, simply some people have some psychological problems and they eat and then after eating they say, okay, I'm going to be overweight. That's not going to work. This is bad. So I'm going to induce my vomiting. They put their fingers inside their mouth and vomit what they ate. So next time, I'm not going to do that again. I don't want to eat that much. I don't want to be overweight. Okay? So, and then you start eat. I still eat it a lot. What should I do now? Vomit. The illicit vomiting. They put their fingers in the back here in the pharynx. Vomiting. So this is a psychological problem. But anorexia, nausea, vomiting is something else. And we should understand this. And what should elicit any one of those? It's the same thing as those. Anything that happens if you have a lot of pain, if you have uremia, like the kidney is having a problem, emotional response. Sometimes you're too stressed out and you feel like you're going to vomit, right? Yeah, all of these will stimulate the vomiting. But the most important to remember is, where is the vomiting center and what are the consequences? And what the vomitus looks like. Very important here. Okay? Each one of those is a very important point. Number one, where is the vomiting center? In the medulla. It's in the medulla, okay? In the brainstem. The vomiting center, that's one. Number two, what happens when you vomit? Okay, listen to this is important. What happens when you vomit? If I ask you, because it's two things that are completely different from each other. It's the opposite of each other. If this is something that, if you're vomiting, you're just vomiting right now, okay? It's something mild. It's early. It's mild. It's not severe. You're going to lose the contents of the stomach, which is the acid, right? You lose the acid. You get a condition called metabolic alkalosis. Metabolic alkalosis. Do we know what's alkalosis? pH goes up or down? Up. So is it metabolic? How to know that's metabolic? Anything that's not related to respiration, call it metabolic. It goes without saying. Did I mention anything about respiration here? It's metabolic. And why is it alkalosis? Because I lost my acid, right? When you vomit, you lose the contents of the stomach, which is mainly acid, right? It's acidic components. So you're losing acid, you get alkalosis. Is that clear so far? This is if it is what? Early and mild. Early and mild. How about this? What if I have severe vomiting? Continuous, severe. You can go to the extent of, next stage, you will start to get the contents of the duodenum now. You can go that deep. You can inject what you have in the duodenum itself. And what you have in the duodenum is a lot of bicarb. Do you remember pancreas releasing bicarb in the duodenum? So now the contents of the duodenum contain bicarb. You start to lose the bicarb. You lose the bicarb.
Is that the sour stuff?
The bicarb?
Yeah.
The sour stuff is mainly the acid. Okay? The bicarb is something like, the Rolaids, antacid and that stuff. This is the bicarb, something like this. Okay? So the next stage is severe. So is it opposite? It's opposite, by the way. If I ask you vomiting, what's the effect of vomiting on pH? You don't answer. Can you tell me, is it early mild or is it late and severe? Because it's the opposite. If I tell you it's early and mild, you lose the stomach contents, you get metabolic alkalosis. Clear? If you do more than that, severe, you start to lose from duodenum. You start to lose the bicarb. So now it's the opposite, it's metabolic acidosis. So at the beginning, metabolic alkalosis, now it's metabolic acidosis. And this is not the only reason for you to develop metabolic acidosis, by the way. It's not just because of losing the bicarb from the duodenum. There is another problem. You're vomiting severely and continuously. Vomit. Now you're losing a lot of fluids, right? You get into dehydration, right? And when you get into dehydration, the kidney will not be working fine and will stop losing the hydrogen. So now the acid will accumulate, and this is the other reason for metabolic acidosis in severe vomiting. Did we understand this? Do you have a question? Is that clear? There are two reasons, not just one. Why severe vomiting? Why do I get metabolic acidosis? Does it make sense? Acidosis. Yes, because you lose the duodenum contents, which is bicarb mainly, and also you get dehydrated. When you get dehydrated, you don't lose the hydrogen from the kidney. The kidney will have a poor function. For the kidney to work good, you have to give them a lot of blood. Blood volume should be okay. You're dehydrated. The kidney is not working fine. Stop losing hydrogen, accumulate metabolic acidosis. Did we understand the two components for making metabolic acidosis? Now the vomitus itself, I mentioned that the system is in, the center is in the medulla. And how do you vomit? It's the forcible expulsion of the chyme from the stomach at the beginning, right? So you take a deep breath, this is how it goes. You take a deep breath, you close here via the epiglottis, and then all of a sudden, contraction, increasing intra-abdominal pressure, ejecting it out, okay? If it is bad enough, you can actually start to get eject from the duodenum. Bulimia, I talked about this, it's an eating disorder, and those patients, I've seen some of these patients, because of doing that all the time, okay, the contents of the stomach goes out, which is acidic. It will start to do erosions in the mouth. So the teeth looks very bad because of the acid continuously going to the teeth. Because of doing this with their fingers, even the fingers themselves will have some abrasions and so on. Okay? A lot of things can elicit vomiting, but it's most importantly anything that irritates the digestive tract, and also some emotional stuff, emotional pain, stress, and so on. And this is a vomiting reflex. This is how we do the vomiting. Deep inspiration, close the glottis, and then open it. Now this is important. Tell me, how does the vomitus looks like? I tell you what you have. Very important to remember. Very important. Are you vomiting? Yes. Is it mild or severe? Is it early or late? This is the first question. You're coming to me, okay? I am a doctor, a nurse, or something. I'm vomiting. Give me some details. Did you just start vomiting and is it mild? Or you're vomiting for quite some time and it is severe? Okay? This is the first question. Second question is, can you describe the vomitus for me? What did you vomit? Okay? If he said that the vomitus is red, contain blood, you call this hematemesis. Does it contain blood or not? Yes, hematemesis. If it is yellow-green, I tell you right away that this is severe coming from the duodenum. The yellow-green color is coming from the presence of bile. And where is the bile? It's in the duodenum. Remember when the gallbladder contract, it push the bile into the duodenum, right? We mentioned that. So where do you have the bile? In the duodenum. Where do you have the bicarb? In the duodenum, right? Where do you have the chyme? In the duodenum. So if you tell me that it's green, yellow, I tell you right away, it's coming from the duodenum now. And it's severe. Green, yellow. What if it is brown? Do you mean blood? No, it's not red, it's brown. No blood. It's brown, colored. Now, it's not coming from the stomach. The problem is not from the stomach. Hematemesis is fresh blood in the stomach, and it comes with the food. So if you describe it to me, you say the vomitus contain actual blood. I can see it. Okay? Now this is not the case anymore. If the problem is in the lower digestive tract, like coming from the large intestine, the small intestine, or something, by the time the bleeding in there at the bottom, by the time it goes up, okay, the blood is broken down and it's not blood anymore. It becomes brownish, something brownish, remnants. And now you describe the vomitus for me as brown. You mean blood? No, it's brown. So that tells me that the problem is not in the stomach or the esophagus, it's coming from something deeper than that, which is the lower part, small intestine, large intestine, basically. Okay? Did we get the difference? Is it blood or is it brown? Blood, stomach, esophagus problem. Brown, under that. How about if it is undigested food? You tell me, I ask you how the vomitus looks like. This is medicine and you guys are working in the medical field. You have to know this. Okay? Describe the vomitus for me. It's all what I ate. It actually still contains the food. I ate some chicken and whatever, spaghetti, anything. It's almost as it is. Very close. It's a little bit of digestive. What that tells me, you have a problem with the gastric emptying. You cannot empty your stomach. You're supposed to contract the stomach and the contents go to the duodenum, jejunum, ileum, right? And continue on. If that's not the case, it didn't leave the stomach in the first place. It didn't leave. Why did it leave? Because you have a problem emptying. So there is a problem with the nervous control of the muscles. It doesn't push it down. Or pyloric. How about this? Pyloric stenosis, maybe. Pyloric problem. Where? Which part? Allow the food or the chyme to leave the stomach and go to the duodenum. Which part? Does anybody remember that? This is the stomach. Okay? This is the stomach. And this is the duodenum stomach. So the food is leaving the stomach. How does it leave? What is this? Pyloric sphincter. Yes. What if you have a problem with the pyloric sphincter? Didn't open, right? So the food didn't even go to the duodenum. It stayed in there. Or the stomach is not contracting, which is called a problem with emptying. How about diarrhea? Diarrhea can be described as I go to the bathroom so many times, or the stool is very watery. I went few times, not a lot, but the content is very watery, okay, very loose. In both cases, it's diarrhea. And diarrhea can be acute or chronic. Acute means I ate something a couple of hours, I'm going to the bathroom too many times. Acute. Chronic means it's happening for a couple of days, for a week, for 2 weeks or something. This is chronic diarrhea, okay? And the problem with prolonged chronic diarrhea is another dehydration, another acidosis, electrolyte imbalance. Did we understand why do we get alkalosis when you vomit from the stomach? You're losing the acid, right? Mm-hmm. How about the diarrhea? You're losing the bicarb. We know that the bicarb is in the duodenum, right? It will move duodenum, jejunum, ileum, large intestine, feces. So the feces should be alkaline, right? So when you lose a lot, you're washing off the bicarb that you have. You get acidosis. Another reason for metabolic acidosis are we following so far? Did you understand this part? Why do we get the pH balance is very important to know. So we get acidosis, diarrhea, get dehydration, acidosis, and acidosis, this is one of the reasons. The other thing is I explained dehydration is going to affect the function of the kidney, and the kidney is trying to get rid of your acid, of your hydrogen. It doesn't get rid of it the way it should. So acid accumulate, acidosis. 2 reasons, not just one. And of course, if you have diarrhea, you are not benefiting from the food, and this is malnutrition. Should the diarrhea be alone or with vomiting? It depends. Sometimes you have both of them, or vomiting alone or diarrhea alone. Okay? Where do you get both of them? Something called gastroenteritis. Gastro means stomach. Enteritis means, what's enter means? Intestine. So gastroenteritis is inflammation of both stomach and intestine, both of them. So I get vomiting and diarrhea, right? Which is even more severe. Now describe the diarrhea for me. Yes, this is medicine. Describe the diarrhea for me. Large volume. It's watery, but it's large volume. I tell you this is called osmotic or secretory diarrhea. And most of the time it will be infection. Most of the time. Infection. Okay? No, the diarrhea is just a little bit. I go to the bathroom, I don't make that volume. It's very tiny, very small. This is another condition which is usually inflammatory process. Another problem. It's not infection. Do we understand the difference between infection and inflammation? Infection is accompanied by inflammation. Inflammation not necessarily coming from infection. Did we get the difference? Inflammation is just a reaction. Pain and swelling and all that stuff. Infection is an organism. right? So there is something called the IBD, or inflammatory bowel disease. Inflammation. There's an inflammation. We will talk a little bit more about that, but describe it for me. Is it large amount, water diarrhea? Is it small amount, which you call it scanty? Scanty means a little bit. No, it is scanty. Can you describe it a little bit more? It have a little bit of blood. It have some mucus secretion, very specific. Some mucus on it. Some blood, some mucus, small amount with blood and mucus. IBD. From just describing the diarrhea. Of course, there will be cramp and pain in the abdomen and everything, but to be very specific, if you tell me the diarrhea is small amount, contained some blood and mucus, that's it. IBD. What type of IBD? I will tell you later on. But this is IBD anyway. You will have some cramps as well. The third one, if you're telling me that the diarrhea is bulky. Bulky is not the same as large volume. Okay? Bulky means big volumes, like big pieces. This is bulky. Okay? Greasy. It looks greasy. The diarrhea looks greasy. And the odor is horrible. This is not supposed, don't say, no, feces smells bad anyway. No. It's horrible. Smell very bad. Somebody outside can actually smell it. Okay? Away in the living room, you have steatorrhea. You have a problem, I can smell it from here. It's that bad. Okay? So if that's the case, I'll tell you that steatorrhea is fatty diarrhea. A lot of fat. And what's the problem with the fat? What's happening here? You did not digest the fat as much. Meaning you don't have enough bile maybe, right? Steatorrhea. And here's what's happening simply. Are we following? The food leave the stomach, go to the duodenum, right? At the duodenum, the bile come from the gallbladder, right? Emulsify the fat. Now the fat will be digested and you don't have a problem. What if you don't have enough bile? For whatever reason. The gallbladder is not concentrating, the liver is not working, the common bile duct restricted, whatever the reason is. What if you don't have bile anyway, for any reason? You don't have enough bile. You do not emulsify the fat, you not digest the fat. And here's what's happening. The fat will go from duodenum, jejunum, ileum, large intestine. You have a lot of bacteria in the large intestine, and the bacteria will say, okay, thank you. You're giving me a lot of fat to work on. It will work on it. Putrefaction, produce a lot of gases, a lot of bad smelling because of the action of the bacteria that's already in your large intestine on that big amount of fat. Did we get this part? That's why the abdomen will be distended, because when the bacteria work on this big amount of fat, produce a lot of gases, a lot of bad smell, and this is steatorrhea. Steatorrhea. What if you're describing the stool for me that it has some blood? Not enough. Not enough. Tell me exactly, what do you mean by that? Do you mean frank blood, like you see easily, it's covered all mixed with blood? This is called frank blood. And this will tell me right away. See how important that is? Just describe it and I'll tell you most likely the condition is. There is frank blood, good amount of blood in the stool. I tell you immediately. This is something happening at the lower, at the end of your digestive tract. I tell you immediately. You have a problem in your rectum or anus. As simple as this. What if you have something called occult blood? Occult blood means hidden blood. Like it's mixed, small amount, and you can barely see it. You can barely see it. This is called the occult blood. And this tells me that you have small amount of blood that is you're chronically losing it. So I will tell you, it's either ulcer or cancer. Okay? Ulcer, bleeding ulcer. Not all ulcers are bleeding. Sometimes you have ulcer that's superficial, it didn't erode enough to the blood vessels, it's not bleeding. But this is one out of two conditions. Describe the stool for me. I see some occult blood, some hidden blood, a little bit hiding inside. I'll tell you right away. You have either ulcer, bleeding ulcer, or cancer. The cancer will be dripping, just drops of blood that will go to the stool and will be hidden in. So occult blood tells me that bleeding, ulcer, or cancer. The other one is melena. Melena. And melena is dark brown colored stool. Do you see blood? It's not blood. Right? It's not blood. You see blood? No, it's just brown colored. Brown colored. If it is dark brown colored, I tell you that this is melena, and usually exactly the opposite of what we talked about before. It is something in the upper part of the digestive tract. Why? Because if you have something in the esophagus or stomach, you have bleeding here, right? This blood in the esophagus or stomach, by the time it go to the stomach, leaving, going to the duodenum, you're digesting it, breaking it down. At the end, it's not blood anymore. It's just a brown color. Did you understand this? There is a difference between blood and digested blood. Digested blood is brown. Blood is blood, bright red. Gases can come from swallowing or the bacteria working on the food. Constipation is the opposite of diarrhea. Less frequent, less than normal. I used to go to the bathroom 3 times a day. Now the whole day long, I don't go to the bathroom. I go to the bathroom once every 2-3 days, for example. This is called constipation. And usually the stool will be hard, and there will be a problem that's happening with the muscles or the absorption of the fluid. You're either not drinking enough water, you have a problem with your muscles, you're not getting enough fibers, and that's why if you're having constipation, they tell you continue to eat something that contain fibers, vegetables that contain fibers. Okay, something like cabbage or cauliflower or stuff like that contain a lot of fibers. So the fibers will make your stool a little bit lighter, a little bit smooth, softer, so you don't have constipation. Can be neurological disorder, some drugs make it, and so on. I talked about dehydration and hypovolemia, and both of them occur because either vomiting or diarrhea, right? When you have a lot of vomiting or diarrhea, you lose water and electrolytes, and you have imbalance of both of them, which is dehydration and hypovolemia. And this will lead to metabolic alkalosis, metabolic acidosis, depending on the condition, and I talked about this. But there is one piece of information that I want to add here. Okay, if this is something that's happening acutely, okay, like acute gastritis, something happened in the stomach right now, acute gastritis. There is acute gastritis and chronic gastritis. Acute gastritis, how does acute gastritis occur? Maybe you have inflammation in your stomach, maybe you got allergic reaction, you're eating something and your stomach acted on it immediately, right? Maybe you ingested a big amount of aspirin, for example, something irritating. So it is something that's severely irritating. Whatever the reason is, if this is acute, something that's happening right now, you vomit acid and you lead to alkalosis, right? If it is deeper and severe, it leads to acidosis. You're losing your bicarb now, right? Here is one piece of information. I mentioned all of that. Here's what I'm going to add. Is that compensated or not? What does it mean, compensated or not? Here's what I mean. This is metabolic acidosis, right? Metabolic acidosis. Do you think your body will stay silent on that? Will say, okay, I have metabolic acidosis, I will deal with it? No, it will try to correct. Try to correct. How are you trying to correct? Your body will say, okay, I'm having acidosis, I'm vomiting a lot, can I stop vomiting? No. So I have acidosis, I need to take care of it? Yes. So I will try to hyperventilate as a reaction, hyperventilate. You start to do like this, so you wash out a lot of carbon dioxide, you wash out the acid, and you compensate. So if you're telling me, here's a question. Is it acute or prolonged? Something that's happened right now for a short time, or something severe and prolonged? If it is severe, you get acidosis. If it stays for some time, enough for your body to react, your carbon dioxide level will go down. And it will start to compensate for it. Carbon dioxide goes down. Did you understand what compensated and uncompensated? Uncompensated, just metabolic acidosis. That's it. Did you do something to correct it? Not yet. It's staying for some time. Your body will say, okay, that's bad. I can't afford this. I'm going to react. Hyperventilate, wash out carbon dioxide, get rid of the acid, drop, correct the pH. Do you understand this part? Compensated or not compensated? Okay. Now, pain. The pain can be of a lot of different types. It can be burning pain, just burning, you described as burning. It can be dull aching. Dull aching is not sharp. Like you tell me, I have pain here. Can you describe it for me? No, I can't really describe it. It's like vague, something, I feel bad. I feel some pain, vague. This is called a dull aching pain, and this is usually capsule is stretching. It can be cramp, and this is usually inflammation or distension. It can be colic, okay? And the colic means recurrent spasm. It goes like this. Your muscles contract, contract, contract to be painful and then relax. Colic, okay? And this is usually inflammation or obstruction. Inflammation because you're irritating the muscles. Obstruction because your muscles are trying to contract to push the food forward, but it's obstructed. Try again. Let me try to push it. It's obstructed. Let me try to overcome the obstruction and push it forward. Okay? So this is for the visceral pain. Somatic pain, on the other hand, this is usually have to do with the spinal nerves, and this would be well localized. Remember that the visceral is ill localized. It's not. Can you describe it for me? Did you get the difference now? Here's the question. I have pain. Can you describe it for me? Vague, dull, or colics like come and go. Can you point out to it? Use your finger. It's here. Yeah, can you use your finger? No, just here, right? This is visceral pain. Something in the viscera. It's not somatic. It's not something for the somatic nervous system. Describe it for me. It's right here. It's right here. If you can localize it, that will be the somatic part. So now your parietal peritoneum, remember the peritoneum is two layers, visceral and parietal. The visceral, which is usually in the beginning, this is visceral. Parietal is somatic pain. So I can tell you, if the visceral or the parietal, visceral means on the organ itself. If it's inflamed or a problem happening to it, you cannot describe the pain. It is visceral pain, dull, aching, colicky, something that you cannot point out to it. If you start to point out to it, it means it either perforated or got somehow to the parietal layer of the peritoneum. Now it is somatic. Referred pain is a pain that's felt somewhere else, not in the region of the problem. We know that heart can be here. Heart problems can be here, right? I have pain in the left shoulder and the left arm. You might have a problem with your heart, all right? Or the gallbladder here. You can feel it in your right shoulder, the gallbladder. Simply the reason is the nerve that's coming from the heart and the nerve that's coming from the left shoulder, they come very close to each other, so the brain is confused. I have two sources, the nerve itself, the wiring, come very close to each other, so the brain will be confused. Is that coming from the heart? Is it coming from the left shoulder? I don't know. What's the more frequent? Is it more frequent to get pain in your left arm or the heart? Left arm, of course. How many times did you get pain in your heart? Almost nothing, right? Maybe one time. But how many times do you get it from the left arm? Maybe 5 times, 10 times, whatever, right? So the brain will say, okay, I don't know exactly, but it looks like it's the left shoulder because most likely it will come from this. And this is called the referred pain. Malnutrition is any of the conditions that we talked about can lead to malnutrition, and malnutrition can be anything. Malnutrition means you don't have enough carb, you don't have enough protein, fat, vitamins, minerals, anything is malnutrition. And all conditions can cause it, diarrhea, nausea, vomiting, any one of those. And some malnutrition is very specific, like vitamin B12 deficiency and iron deficiency. This will lead to anemia. Diagnostic tests, you can do ultrasound to tell you exactly what, or give you a rough idea actually radiography or ultrasound, just to give you, if it's a mass or something, you can tell by the sonar. CT can tell you, MRI can also give you an idea about what's happening. You can use the endoscope, like if you have a problem in the stomach, I put an upper GI endoscopy, goes from above and tells me, visualize with your eyes, visualize what's happening in the stomach, and you can take it from the other side, from the bottom side, enter it from the anus, and that can tell you what's happening in the colon, sigmoid, and rectum, which is the last part of the large intestine. And this is, by the way, it's routine after the age of 50. This one specifically, which is colonoscopy. It's preventive care. Anybody, especially men who are over 50 or over, they do it automatically every 10 years. But if there is polyps or something that can be precancerous, they do it every 5 years. Other things can be liver function, cancer, and so on. Treatment, it's not the most important, but dietary modification is usually something that you start with. Reduce the bad stuff. Obviously, alcohol is bad. There are a lot of problems with alcohol that we will talk about. And coffee, it can produce irritation, gastritis, ulcer, and so on. Increase fibers. This is generally speaking, by the way, it's very good to do. If you're having a problem, always start with dietary modification, especially if we're talking about the digestive tract dysfunctions, okay? It's always good to eat fibers, whether you're old or young, it doesn't matter. Eat fibers, okay? Drink a lot of water. This is always good. Drink water. Reduce or cut off alcohol and coffee. This is celiac disease. This is a very special situation that needs dietary modification, and that will be the main treatment. The main treatment is cut it, and we will talk about it. If you have a stress, try to reduce it. If this is something that needs drugs, take drugs. Like what? Antacid, for example. Like over the counter, we have Rolaids, Tums. We know that stuff, right? So you take it if you have a little bit of acidity. If you have vomiting and we don't know the reason, we can give you antiemetic, laxative for constipation, anti-diarrhea for diarrhea. This is just symptomatic treatment, but it's always good to know what is the reason first. Not like, I have diarrhea, give me anti-diarrhea. No. We need to try to know first what's happening or what's causing the diarrhea before giving you anti-diarrheal. You know why? Sometimes diarrhea is a protective mechanism. We know that, right? Sometimes you're having diarrhea because you ate bad food and your body's trying to get rid of it. Why would you stop the diarrhea? What should I do then? Compensate. Drink. Drink water? No, not enough. Drink water and source of electrolytes. Something like Gatorade. This is something that's good if you have diarrhea, and most likely it's coming from food that's bad a little bit or something like that. Just leave it alone. Your body's trying to get rid of it, of the bad stuff. Just drink enough water, enough electrolytes, something like Gatorade or juice or something like that. That will be good enough. Other types of treatments depending on the condition. Anticholinergic, H2 antagonist, something like cimetidine, ranitidine, something like that. If you have a gastric reflux, proton pump inhibitors like Prozac, Prozac. Proton pump inhibitors, something to reduce gastric secretion if you're having Prelosec. Are you familiar with this? So ranitidine is something, Prelosec is something else. This is to decrease the secretion if you have a lot of heartburn. And this is summarizing all of this. The treatment is not the most important, just for your information. Upper GI problems. The first one is condition can be congenital, can be acquired. Congenital is something like cleft palate. Did you ever see something like that or see a picture before? The palate is not continuous. The palate have a cleft like this. Okay? A cleft like here. Simply, do you know the hard palate and soft palate? They start as two parts in the uterus. Okay? So the fetus starts like this, two parts, and then it go like this, and then they blend. If you didn't blend, the hard palate and soft palate, you have cleft. And the problem with the cleft is food can go up to the nose from here, okay? So those two parts did not blend. This is called cleft palate, and usually it's in the first trimester, the first part of the pregnancy. It can, and this usually they surgically corrected. Other problems with the oral cavity, something like aphthous ulcer, inflammatory ulcer. This is an ulcer, small ulcers that are painful, and most of the time it's caused by Streptococcus sanguineus. And Streptococcus sanguineus is one of the normal resident flora, but it gets too active. Candidiasis or candidiasis, this is a fungal infection. Candidiasis is a fungal infection. And if you ever seen this before, the patient open the mouth and you see white stuff in the mouth. If you ever seen that before, white stuff in the mouth. So this is candidiasis. Do you know that all of you have fungi and bacteria and virus in your mouth? We all have it, right? Why some people get infected with it and some others do not get infected? Normally, you shouldn't. So the exception is that you get infected with your normal resident. What can happen to induce that? You're using a lot of antibiotics, okay? You're taking cancer therapy. You're using something immunosuppressive, like this, like people having bronchial asthma. If you have bronchial asthma, they give you the beta agonist, right? Which is the Ventolin or albuterol or something, right? Sometimes if you have a chronic problem, they add cortisone to it. We know that, right? And cortisone go to the mouth, and if it goes to the mouth, it's going to activate. It's going to suppress the immunity and activate the normal resident that shouldn't do anything. And the fungus will say, okay, so you're activating me, I wasn't doing anything, so I'm going to flare up, I'm going to invade your mouth. Okay? The fungus is not strong enough to do that. Only if you give it the opportunity, and that's why they call it the opportunistic infection. Opportunist. You give them the opportunity to do so. Because of any one of these reasons, it will be red, white patches. Like this. Look at this. These patches. You see this? If you open the mouth and see something like that, you ask the patient right away. This is not normal. This is fungus. Are you taking glucocorticoid? Are you taking any immunosuppressive? And so on. The next one is herpes simplex. Herpes simplex. There are two types of herpes simplex. Type 1 is in the mouth. Type 2, genitalia. And this is not the issue now. We're doing the digestive tract. So here is the thing with the herpes simplex. Somebody's infected with herpes simplex, okay? And you get in contact with him somehow, okay? You can use any of his stuff, whatever he's using, cloth or washing or whatever you're using, something that he's using. Sometimes it comes with kisses or something like that. Any source that the herpes go to you from somebody who's infected. It is what's going to happen. It go to the mucous membrane or the skin, enter, travel through the sensory nerves until it finds the sensory ganglia, hide there. It doesn't do anything. Are we following? It hides, it go backward with the sensation, with the sensory neurons, go up, 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 until it finds the ganglia, which is a collection of bodies. It hides there. It doesn't do anything. Just hide, okay? And now you're having a problem somehow, whatever the reason is, your immunity is suppressed. It will flourish in the ganglia, start to leave the ganglia and go backwards to the skin, causing these lesions. And this will be a lot of people, by the way, huge amount. Have it, you start to have like vesicles here, painful, here, or here, at the bottom here. You start to have this, especially if your immunity goes down. Like what? Simply after you have flu or common cold or something, your body is busy fighting the virus, right? And this herpes simplex will say, okay, obviously you're weak, I can leave the ganglia, I don't have to hide, you're weak, so I leave the ganglia and go backward until I go to the skin, causing these vesicles, painful vesicles. And what happened later? After you're done with the virus, your body starts to recover, You start to gain back your immunity, so these viruses will be scared. You're not going to kill them. They go back and hide in the sensory ganglia again until the next time, and go back and forth. And this is the explanation why it is recurrent. If I ask you why the herpes simplex is recurrent, because it hides in the sensory ganglia, goes, makes some inflammation. You regain, it goes back, hide. And this is the reason why. Anything that happens, you have inflammation, you have infection, you have stress. Even during stress, by the way. Sometimes you're too stressed. Do you know that during stress, your immunity goes down? Suppress immunity. So because of glucocorticoid, by the way, cortisone. So you start to see this just after stress, not necessarily an actual disease. Syphilis is sexually transmitted bacteria, Treponema pallidum, and there are 3 stages of that. The first one is what we need to know because it belongs to the digestive system, which is painless ulcers on the tongue. Open your mouth, show me the tongue, show me the lips. I see ulcers. Is it painful? No. Syphilis. Okay? This is primary. And this is in the beginning, and then it goes to secondary, which is macules, and then it goes to the tertiary, which is in other spots. Dental problems. There is a bacteria that's called Streptococcus mutans and another one that's called Lactobacillus. Those two. They are normal inhabitant in your mouth. All of you have it. All of us. We all have it. You all have those two. Streptococcus mutans and Lactobacillus. Everybody have it. Why some of us get dental caries and others do not get it? Why? If you brush your teeth, when you brush your teeth, you're getting rid of the nutrients, right? Specifically carbohydrates, sugar. You get rid of it. But if you don't brush your teeth on a regular basis, you're supposed to do it every day. If you don't brush your teeth, sugar accumulates. And these 2 types of bacteria that are very weak, they cannot even do anything. They cannot invade your teeth. But now, you are giving them a lot of nutrients, right? So they will start to become stronger and start to invade your own teeth. Dental caries. This is one thing. The other thing is, this bacillus, from the name lacto is coming from lactic acid. So when these bacilli start to flourish, they produce lactic acid, and this lactic acid dissolve your enamel. Do you know that the enamel is the hardest part, strongest part of your teeth? Yes, they start to erode. So there are 2 reasons. And all of it is just brush your teeth, right? Brush your teeth. That's it. Clear up the remnants. Otherwise, you are actively feeding. You're feeding your bacteria. It's very weak. It cannot even do anything. Very weak. But if you feed them, they will become stronger, invading you, and this is dental caries. Fluoride is something good. If you do that on a regular basis, it will increase the resistance to these bacteria. But of course, brushing your teeth will be the best. Gingivitis is just inflammation of the gingiva. Become red, swollen, and painful. Just because of the dental hygiene. And it can come from that you're choosing the bad toothbrush. Do you know what toothbrush should you use? No, I'm talking about soft versus medium versus hard. Soft. You're supposed to use the soft. Medium, maybe. Hard, of course not.
Toothbrush don't say if they soft. Do they?
Soft, medium. What's the idea of the brush in the first place? Do you think you're trying to take out a layer of your teeth? You're not supposed to do that, right? All what you're doing is just clean, right? So soft. Soft is number 1, okay? I know some of us will get the teeth hard. Let me clean my teeth so it will become white and nice, right? You're not supposed to do that. Or what you're trying to do, just clean, soft. Use the soft. Maybe medium, hard, bad. Gingivitis. Periodontal disease. Peri means around. Dontal means teeth. So periodontal disease, these are diseases around the teeth and the surrounding of the teeth. So it get the ligaments and the bone. Okay, and it can lead to gingivitis. This is a healthy teeth, looks like this, clean. Look at the periodontal disease. The teeth itself is infected, but that's not it. It goes also, are we following? It goes to the bone that's holding the teeth, which is the alveolar bone. You know your upper teeth is in the maxilla, and the lower teeth is in the mandible. This does not only infect the teeth, it infects the surroundings as well, which is the bone, the alveolar bone. Okay, both of them. So, periodontitis is a bacterial damage of the teeth and the alveolar bone surrounding it. Let's say this is the upper row of teeth, like this. This is a bone, this is bone, bone, bone in between here. So both teeth and bone, both of them will be infected. Periodontitis. Periodontitis. And this needs antibacterial treatment. It's bacteria. Periodontitis is bacteria. Other problems, hyperkeratosis, just thick white patches on the mucous membrane. Different types of cancers. Squamous cell carcinoma. There are other types, but this is the most frequent one. Small squamous cell carcinoma. Okay? Squamous cell carcinoma is more frequently if you are smoking. Leukoplakia, these patches, white patches that I talked about, this is precancerous. A lot of alcohol can predispose to the squamous cell carcinoma, and location is very important. Side of the tongue and the floor of the mouth. This is your tongue, sides, and the floor of the mouth. This is the most frequent location, most frequent spot for squamous cell carcinoma. Is that the only carcinoma? No, it's not. But always remember, you need to be smart when you study, okay? It's not just taking everything as it is. You don't just get everything. No. There is always what's the most common, what's the most important, okay? What's the most prevalent, what's the most, right? So what's the most common? It's squamous cell carcinoma. Is it the only one? No, I care more about this. This is the most common. And where is the location? Why does it come? There are others, but this is the most important one. Other disorders of the oral cavity, sialadenitis, just know that this is inflammation of the salivary glands. Do you know your salivary glands? Salivary glands, submandibular, sublingual, parotid. Yes, if they got inflamed, you call that sialadenitis, and this is good enough. Viral infection of the parotids is a special situation. Viral infection of this. Do you know that parotid, submandibular, sublingual? Do we know that? Yeah, parotid, specifically. If it gets virally infected, viral infection of the parotid gland, this is called mumps. And you can fight that by a vaccine that's called MMR. Are we familiar with this? Okay, so there is a vaccine for that. Some other types are not infectious, but this is more important. Dysphagia. I'm trying to eat, I have difficulty swallowing. I'm eating, I have difficulty swallowing. Dysphagia. This, D-Y-S, is a prefix that means difficult. Are you collecting all these prefixes and suffixes? It will help you, trust me. This, difficulty. Phasia, eating, swallowing. Dysphagia, difficulty swallowing. Why do you have difficulty swallowing? Something happened in the pharynx and esophagus. Remember that swallowing is a complex process that is coordinated by 5, 9, 10, 12. Do you remember this? So all of these nerves work together. What if you have a problem with this coordination? A nervous problem, muscular problem, or you have muscular obstruction, like what? Like you have a problem in your esophagus and start to get fibrotic and become stenotic for some reason, right? So you have a difficulty swallowing. Can be from neurological problem, muscular problem, can be mechanical problem. And when we talk about mechanical problem, there is a condition that's congenital problem that we will need to know, which is congenital atresia. Atresia, what does it mean? A means, a prefix, it means without or no. Atresia means formation. Atresia means formation. It's a suffix that means formation. Okay? So atresia means no formation, or without formation. No formation. No formation of what? It looks like this. This is the esophagus here. This is the esophagus, right? In the fetus, in the first trimester, it doesn't go like this. It goes in different parts. Like 3 parts, okay? And then they unite together. Sometimes one of them is missing. Something like this. Okay? And it will be something, maybe something like this. Or completely missing, depending on the situation. So atresia, congenital atresia, the upper and lower part are separated. Where is the middle part? It didn't form. So the upper and lower part will be separated from each other. Okay? And what's the condition? The baby is born. Okay? The baby is born. Of course, the fetus does not eat, right? He get everything via the blood. So you didn't know. You didn't know during pregnancy, right? But here is the mom saying, I'm trying to breastfeed the baby, and every time I feed him, he vomit exactly what I give him, as it is. He just eat a little bit and vomit, okay? So the food and drink doesn't even enter to the stomach. And this is called congenital esophageal atresia. Did we get this condition? Surgical correction is needed. The other one is stenosis of the esophagus, and this can be something developmental or congenital anomaly. So it's another condition that is, it's not, remember atresia is the upper part and the lower part are separated. Did you get this part? This is another condition. It's not separated. It's continuous, but it goes like this. Okay? Congenital. So this part started to develop a little bit, but not enough. Stenosis. Sometimes, so this is congenital. Did you get this part? Congenital stenosis. Stenotic. Can be congenital. Can it be acquired? Yes. Here is a completely normal esophagus. And you start to inflame this area. Inflame. Fibrous tissue start to surround this area, narrowing it. And this is the acquired one. Sometimes it's a mechanical obstruction by somebody's having a tumor that's making the lumen narrower. Sometimes diverticula, and diverticula is outpouching, basically. It's outpouching like this. Something like this. Okay? This is called diverticula. Outpouching of part of the wall. These are the different types of dysphagia, but we got the most common reasons. If cancer happened in the esophagus, it is squamous cell carcinoma. Why? Because of this. From here to here, anything in between my 2 hands, squamous cell. Anything from here to close to the end is columnar cells. Why? Squamous cell is for mechanical protection. The food is hard. You need to be mechanically protected. Columnar is chemical protection because of the acid, and it helps you to absorb as well. So it will be squamous cell carcinoma. Most of the time it's the distal part, like here. This is the most frequent one. And one of the reasons that predispose to this can be chronic gastritis. You have gastritis all the time. You have achalasia, and achalasia is changing the squamous cell carcinoma to columnar one. Irritation by alcohol or smoking can cause that as well. Next abnormality is hiatal hernia. What's hiatus? What's hiatus? The hiatus is the opening in the diaphragm that allows the esophagus to go through. Okay? We know that the diaphragm is separating the abdomen from the thorax. We know that, right? The esophagus should go from the thorax to the abdomen. How does it go? There is an opening. in the diaphragm. That's called hiatus. The hiatus, diaphragmatic hiatus. Are we following so far? Okay, so we have this hiatus. Two conditions can occur. How about if you're having a lot or a continuous increased intra-abdominal pressure? You're coughing a lot, you have distension a lot, you have something that's increased intra-abdominal pressure. You know what happened? You push the stomach up, 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 until it starts to make this hiatus wider. And it will start to go up. So hiatal hernia is because of increased intra-abdominal pressure. It can be sliding, the sliding type of hiatal hernia. And this is portion of the stomach pass up. What goes through the hiatus should be like this. Esophagus and the stomach is here. It go like this. Okay? Slide up. So part of the stomach will exceed and go to the thorax. And the problem is the closing, the lower esophageal sphincter will be weak. And the contents of the stomach can actually go to the esophagus. And this is a problem. There's also paraesophageal type of hernia. And as I mentioned, the problem with that is, look at this here. This is a diaphragm, okay? This is a hiatus. If this is wide, so the stomach will start to go up. So let's say it will be like this. Part of the stomach will be protruding out, like this. So the sphincter here is not closing as good as it should. So the contents here will start to go up to the esophagus. Stomach contents, is it supposed to go up to the esophagus? No. It will burn the esophagus, burn it. The esophagus is not prepared to deal with acid. So it will start to cause esophagitis, inflammation here, and this can be precancerous. Heartburn and chronic esophagitis. Did you have heartburn before? You had heartburn means the acid goes to the esophagus. It's not supposed to, right? It have nothing to do with the heart, but because it's closed, so we just call it heartburn. Now what's a GERD? Gastroesophageal reflux disease. This is the GERD, or GERD, which is a periodic reflux of the gastric contents. Every now and then, the content of the stomach go up to the esophagus. Reflux goes up, leading to erosion and inflammation. Sometimes the gastric emptying is a problem. Okay, the stomach contents are supposed to leave and go to the duodenum, and it is delayed for some reason. Delayed. Stay for a long time and start to go up. Maybe something is irritating the stomach, so the contents goes up, something like coffee or alcohol or something. Now gastritis. What's gastritis?
Inflammation of the stomach.
Inflammation of the stomach. It can be acute, it can be chronic. It can be acute, it can be chronic. Acute, something happened all of a sudden. Meaning you got something that immediately irritated your stomach. You call this acute gastritis. Okay? Something like what? Like infection. You got something that have a bacteria that's very virulent, active, and it irritated your stomach. Gastritis, acute. Sometimes it's allergy. Some people have allergy to shellfish and they don't know. Eat, stomach react immediately, inflame, acute gastritis. Can be something spicy, alcohol, something like that, irritating your stomach right away. Acute. Chronic is different. Sometimes medication and so on. Chronic will be different. But how to know that you're having acute gastritis? If you're having gastritis, what are you going to get? Vomiting. And sometimes there is bleeding. The pain is epigastric. Where is the epigastric region? Where is your epigastric region?
On top of the stomach.
Where? Here? This is the epigastric? Yes. This is right hypochondriac, left hypochondriac, and this is epigastric. This part specifically. So the pain will be here, vomiting. Some of the vomiting will contain blood, and you call it hematemesis. If you see this combination, vomiting, some blood, pain, acute gastritis equals acute gastritis. Okay? If there is infection, there might be some diarrhea as well. What should you do to the acute gastritis? Supportive, nothing. You're not supposed to treat acute gastritis. It will go away. How about chronic gastritis? Chronic gastritis is a different scenario. Okay? It's not something that's too irritant or too active enough to immediately cause something to the stomach. Here is what's going to happen. The mucosa of the stomach will be gradually. You lose it gradually. It becomes atrophic. Do you know what atrophy means?
Abnormal.
Abnormal
no.
what?
Big. Size.
Atrophy. Atrophy versus hypertrophy. Atrophy.
Loss of muscle mass and hypertrophy is like abnormal gaining of it.
Yes, not necessarily muscles, of anything. Yes, you're right, but not necessarily muscles. Here it's the mucosa. Atrophy means you lose the thickness. Hypertrophy means you increase the thickness. Atrophy, hypertrophy. This is your stomach wall. Look, it's becoming atrophic. Did you understand this? Atrophy, no building. It become atrophic. Why? This is chronic. Because you're chronically irritating it, not enough to cause acute. So if that's the case, you will gradually lose your mucosa inside, and you don't secrete. Secretory glands will be lost. You don't release mucus secretions and other secretions anymore, including the intrinsic factor. Chronic gastritis can lead to peptic ulcer. Okay? And there is a situation here. Helicobacter pylori is a bacteria that was discovered, I would say like 20 years ago only. And here's how they found it. I'm having heartburn. Okay, avoid coffee, alcohol, all that stuff. I still have heartburn. What should I do now? Try some antacid. Didn't go away. I still have heartburn. Okay, I have to give you some medication. Here is antacids or whatever the medication is, ranitidine or something. I still have heartburn. What should we do now? They started to use the endoscope. Let's go inside, take a sample from inside and see what's happening there. There is something unusual. You tried everything. It's not working. Accidentally discovered it. So they went with the endoscopy and they got the sample from inside and they started to analyze. It looks different to them. So they take a sample from that and they analyzed until they found that weird type of bacteria that's called Helicobacter pylori. If you treat this, everything will be good. So you can get treatment for 6 months or a year, nothing happened. And just take a dose of antibiotic, erythromycin or something, you wipe it off, you're fine. What's the problem with Helicobacter pylori? What's the problem with that? You don't really feel much with the Helicobacter pylori. But the problem is, Helicobacter pylori, they secrete an enzyme that's called protease that dissolve your mucosa. Dissolve it, causing peptic ulcer. So if this is a person who's having heartburn and peptic ulcer, and I mean it's more of a peptic ulcer that's not healing, okay? Peptic ulcer. So you're having a peptic ulcer that's not healing. Give you treatment for peptic ulcer, didn't work. Helicobacter pylori. They produce some toxins, Helicobacter pylori produce some toxins and protease. You need to remember this. Toxins and protease. Those two will always erode, keeping on having ulcer. Give you treatment, doesn't work. Helicobacter pylori. Chronic gastritis can lead to peptic ulcer and gastric carcinoma. There is one type of chronic gastritis that's autoimmune. You have antibodies against your own stomach cells. Gastroenteritis is simply inflammation of both stomach and intestine, and most likely it's infection. These are the different types of bacteria that can come from the food or water. But we have some of them that's more important to focus on. E. coli. E. coli is a normal inhabitant, but sometimes there are more aggressive strains that can invade. Now peptic ulcer. What's a peptic ulcer? Peptic ulcer is ulcer. Are we still following? Are we still okay? We're fine? Okay. So what's a peptic ulcer? Peptic ulcer is ulceration of either the stomach or the first part of the duodenum. Unlike what we usually hear. Ulcer is in the stomach, right? Not necessarily. Ulcer is actually more common in the first part of the duodenum. Okay? Proximal duodenum is the most common location. Should I know that ulcer, generally speaking, come in the duodenum and the stomach? Not enough. It's more common in the proximal duodenum, specifically. Specifically. Okay? The question is, this will be followed by the antrum of the stomach, and the antrum is this part. But what's the most common location for peptic ulcer? Proximal duodenum. Proximal duodenum. Most common. Antrum is the next one. But what's the most common? Proximal duodenum. Specifically. Okay? Now the question is, what makes peptic ulcer? Peptic ulcer, you're losing the mucosa, right? Ulceration. What can make that? One out of two. Either the mucosa become weak for some reason, or Helicobacter pylori that's producing something, your mucosa is not weak. But this bacteria is releasing proteases and toxins that erode your mucosa. You have two reasons. Weak mucosa, or the mucosa is not weak, and just the Helicobacter pylori is eroding it. What are the reasons for your mucosa to be weak? The secretion of the mucosa itself is declining, breaking down. Okay? This is one reason. You are producing a lot of acid. I'm talking about, are we following with the peptic ulcer? Peptic ulcer is ulceration. What's the reason? Major categories, one of those two. Helicobacter pylori or weak mucosa, mucus lining. Helicobacter pylori. Why? Because it secretes protease that break down, dissolve your mucosa and toxins. Both of them break down and dissolve. The other one is weak mucosa or a lot of irritation. One of them is inadequate blood supply, like vasoconstriction, especially in stress and shock. Did we hear about stress ulcer? This person is always stressed out, he's very nervous, he's always having problems, right? He's always angry, and he ends up having ulcer. Did you hear about this? Why? What's happening here? What's the pathophysiology of this? Why people get something like this? Here is why. Do you guys remember in the beginning when I mentioned the sympathetic versus parasympathetic nervous system? Okay? So with the sympathetic nervous system that's activated during stress, what happened to the blood supply to the stomach and the digestive system in general? Increase or decrease? Decrease. This is not the time, right? So the blood supply is decreasing. So the rate of rebuild, you rebuild the mucosa every hour or something. It's very frequent. So if less blood supply coming to the stomach, it means the mucosa will be weak. Vasoconstriction of the digestive tract, which is sympathetic, which is stress. Did we get the link between those two? Stress and ulcer. Why? Because of vasoconstriction. This is one. Number two, medications. Glucocorticoid suppress, whether you're taking it as medication or you're secreting it inside, glucocorticoid suppress the reproduction of the mucus cells. Okay? Some types of medications like aspirin, alcohol, irritate the mucous membrane of the mucosa of the stomach or duodenum, so you lose part of it and you get ulcers. Chronic gastritis is another reason. Increase acid or pepsin secretion. Why? Acid, I thought my stomach is prepared to deal with acid, right? I mentioned that several times. Your stomach is lined by columnar epithelium. It's very resistant, very chemically resistant, So it's resistant to HCl, but it doesn't mean you drink HCl, right? It's not to that extent. It's protected against reasonable amount of HCl. So if HCl is produced a lot, how about pepsin? What's the pepsin, if you're following?
It's the hormone. It breaks down stuff.
Break down what? Proteins. It's a proteolytic enzyme. So if you're secreting too much of this, like what? Like certain types of tumors of the stomach produce more of those. So that's going to irritate and erode part of your stomach, causing ulcer. How about excessive vagal stimulation? Do you remember when I told you that the vagus nerve is the main parasympathetic nerve? And does the parasympathetic increase or decrease secretions? Increase secretions. So increases secretions including pepsin and HCl eroding the stomach. Are we following so far? The things that I put line underneath is not the only ones, but the most important of all. Did you get the reasons for peptic ulcer? Gastritis, chronic gastritis, atrophy, you're eating something, drinking something, you're taking treatment, something that increases secretions of gastrin, and so on. What are the complications of peptic ulcer? You're having an ulcer, what can happen as a consequences of this, or complications? Number one, the ulcer is you're losing erosion of the wall, right? If this erosion continue, it will perforate. If you heard about perforated peptic ulcer, did you hear about this? Perforated peptic ulcer. So it can erode enough to perforate. And what's the problem with that? Can you tell me what is surrounding your stomach? What's surrounding all the abdominal organs? What's that bag? Surrounding all the abdominal organs. Yes? Huh? What is that bag? What's the bag? This is for the lung. How about the abdomen? Start with P. P-E-R. Peritoneum, yes. Peritoneum. Peritoneum is around, right? Peritoneum. It's surrounding all these organs, right? So guess what? If you have perforation, the contents of the stomach is going to leak out of the perforation and go to the peritoneum, causing something called peritonitis. So perforation can lead to chemical peritonitis. What's chemical peritonitis? Means the chemical compounds in the stomach leaks out and inflame the peritoneum. Did we get this? Chemical, what kind of chemicals? HCl and enzymes, right? Hemorrhage, if the peptic ulcer erode enough to go to the blood vessels, you will start to bleed. You get bleeding, okay? And this can, sometimes is the first sign of peptic ulcer, right? How do you know that you have a peptic ulcer? I started to get, what do you call this? Blood in the vomitus. Hematemesis, yes, hematemesis. I get in the vomitus, I started to vomit, and I see some blood. Sometimes it's the first, which is one of the complications. Obstruction can be something, but that's very late. And here's what's happening. Here's your duodenum, right? Okay? You have ulcer. The ulcer will start to erode, taking more time. Inflammation taking longer time. You start to get fibrosis. And if you have fibrosis, the fibrous tissue is going to constrict. Obstruction. Did you get this point? If you irritate enough, erode enough, injure enough for a long time, result is fibrosis. But this is long term. For this to happen, it needs years and years to occur. So hemorrhage, perforation, and obstruction. Signs and symptoms depend on the location, but you will have burning pain or localized pain. Can you tell me when it's burning and when it is localized? When do you say like I have here? Yeah, can you point out to it? No, it's just here. This is a visceral pain, which is at the beginning, gastritis or ulcer. If it's perforated, it go to the peritoneum. It's not visceral anymore. It is somatic, and now you can tell me it's exactly at this point. It's usually a complication. It means it's perforated. How to know for sure that you have an ulcer? Endoscope. Okay. Treatment: if you have H. pylori, kill it. Otherwise, guess what? If you have peptic ulcer, it can stay for years, and nothing will happen. Take any medication you want; it will not correct the situation until you get very simple medication eradicating the H. pylori, and now you're fine. You can use other medications depending on the cause. Proton pump inhibitors, something like Prelosec. H2 inhibitors, something like ranitidine or cimetidine or something like that. And avoid anything that is eroding your stomach. What can erode your stomach? Can you tell me what can cause irritation of your stomach? Spicy food, certain drugs, alcohol, caffeine, right? All of this can irritate. Cut on those. And this is called a dietary modification.
What about for the ulcer? How is it corrected? What's the treatment for it?
The treatment for ulcer, if you stop the exacerbation or if you stop irritating the ulcer, it will heal itself. The mucous membrane is going to reproduce. It's going to correct itself, okay? Regenerate. It's going to regenerate. Just stop irritating it and it will regenerate itself. That's basically what it is. Stress ulcer is a specific condition, and I told you if you have a lot of stress. What kind of stress? Just stress, you're stressed for some reason, or severe stress. Severe stress, like if you have burn. If you have burn, aren't you going to be extremely stressed, right? You have a problem in a head injury, sepsis, something like that, you're extremely stressed. And do you remember what happened during stress? Sympathetic, less blood supply, constriction, right? So the stomach will start to erode. And stress ulcer specifically, you start to see hemorrhage and severe pain. This is usually the first indicator. So if you're telling me, if I'm thinking about ulcer, and I wanted to know what kind of ulcer, besides you're telling me that you're under a lot of stress, that's one thing. But what are the signs and symptoms? You're vomiting, containing blood, hemorrhage, and severe pain. So this is something that happened all of a sudden. Did we understand the difference between those two? Stress ulcer specifically is something different. And by the way, stress ulcer is not one ulcer. If I put the endoscope, it doesn't look like the regular peptic ulcer. Peptic ulcer is 1 or 2. This, you will see a lot of them. 10, 15 spots, but very small. Okay? Did we understand the difference? Look at this picture here. 1, 2, 3, 4, 5, 6, 20, 25, whatever the number is. But the regular peptic ulcer would be something like 1 big or 2 or something. That's it. So this is what's different in a stress ulcer. And remember, it's all of a sudden, it's severe pain, and most of the time there'll be hemorrhage because it happened too acutely. Gastric cancer. Gastric cancer, most likely it's adenocarcinoma. Most common location, antrum and pyloric area. Yes, specifically. Can I say stomach in general? No, you can't. Not in general. It's antrum and pyloric area specifically. More common, adenocarcinoma. The problem with the stomach cancer is it's at the beginning, it's asymptomatic. No symptoms at the beginning, so it delay the diagnosis. These are irritants enough to the stomach, not to cause gastritis, actually to cause cancer. And you should avoid it. You know the smoked food, some of us like it, right? This is very irritant, carcinogenic. Anything that's preserved with nitrites, this is bad. Smoked food is bad. Yes. It can irritate the stomach enough to produce cancer. Takes longer time, and it should be a lot, but it is. Nitrites and nitrates, these are preservatives. If you get that container and read, if it is preserved with nitrates or nitrites or nitrates, this is bad. Try to avoid it. Genetic factors can play a role as well. Dumping syndrome. What's a dumping syndrome? You know when you dump something. Dumping syndrome is you cut the stomach for any reason, and the food got from the esophagus to the intestine all of a sudden. A big amount of food go all of a sudden to the stomach, to the intestine, not gradually as it should. Of course, you didn't have the time to digest, so this will go undigested, which is hyperosmolar chyme, and it can lead to distension, colic because of motility, and drop of the blood pressure can lead to syncope. And here is a classic presentation to the doctor. I had surgery. I removed most of all the stomach, and I ate a good meal. And 2 or 3 hours later, I start to have abdominal distension, colics. I feel really bad, miserable. You're not supposed to eat that much. You're supposed to eat very small meals more frequently. Or you will get this condition and you get hypoglycemia. Hypoglycemia 2 to 3 hours after the meal. Hypoglycemia. Pyloric stenosis. It's a stenosis of the pylorus, so it's here. Of the pylorus. The pylorus becomes stenotic, something like this. And this can be congenital or acquired. Okay? And if that's the case, do you remember this? Pyloric stenosis, the food go to the stomach, and if you vomit the food. Do you remember? Tell me how the vomitus looks like. If the pylorus is closed, it doesn't even go to the intestine. Stomach content is vomited as it is. Pyloric stenosis can be congenital, which is hypertrophy of the muscles of the pylorus, can be acquired. Liver and pancreas. These terms are all important to know. Cholelithiasis. Chole means gallbladder. Lithiasis, and you're going to use lithiasis more than one time. Lithiasis means stone. Cholelithiasis, stone in the gallbladder. Okay? Stone in the gallbladder. Cholecystitis, inflammation of the gallbladder. Cholangitis, inflammation of the bile duct. Choledictolithiasis, choledocho. What's choledictolithiasis? Docho or D-O-C-H-O, docho. This means the bile duct. And obviously, so this is not a stone in the gallbladder itself. It's in the bile duct. And the clue here is this, docho. Docho means duct. Docho duct. Okay? It's not the bladder itself. Most of the time, if we're talking about the gallbladder stones, most of the time it will be cholesterol and bile pigment specifically. Can it be something else? Yes. Are we following what I mean when I say it's not just memorizing everything as it is? Yes, you can tell me it can be cholesterol, it can be bile, it can be calcium, it can be bicarb, yeah, that's all good. But this is not the issue. Which one is the most frequent? Which one is the most common? It's not a list. You have to tell me what's number one. Specifically, it's cholesterol and bile pigments specifically. These are the most common ones. Now, what is the fate of cholelithiasis? If you have a stone in your gallbladder, what's the fate? It depends on the size. Okay, doctor, can you tell me I have stone, what's going to happen to it? Well, it depends on the size. If it is too small, it will pass through the cystic duct, go to the common bile duct, duodenum, it go in the stool, you're fine. If it is larger than that, it's not going to go away. So it can obstruct the cystic duct, and the gallbladder will start to distend, causing pain and colic and that stuff. And the treatment for that case is either surgery or infrared to break it down and loose it. So it depends if it is small or large. Gallbladder stones specifically occur in females who are obese and multivariate. like she had 5, 6, 7 kids, and she's obese, female. This is a good combination, eating a lot of cholesterol and stuff. This is something that's predict, risk factor. If this is large stone or calculus, it can actually close the ducts, and this will cause nausea, vomiting, and pain. And it can be followed by jaundice, which is jaundice, yellowish discoloration of the skin and mucous membrane. Jaundice. What's the jaundice? Here's another condition. And by the way, jaundice and hepatitis is the most important of all. It's very important to know. So what's jaundice? It's yellowish discoloration. It can be 1 out of 3. Look at this. Here is your liver. Understand this. This will wrap it up. Look at this. Here is the blood. You break down the blood, produce bilirubin. Bilirubin go to the liver. It will become conjugated. You add something to it, become conjugated. And then you release it through the hepatic duct, common bile duct, and so on. So this is what's happening under normal circumstances. 3 conditions can occur. A problem here before the liver, which is called prehepatic, that you're breaking down your blood too much. You're having some problem, a hemolytic anemia, for example. You have hemolysis. Beyond the capacity of the liver to conjugate. What are you conjugating? Because when you conjugate, it can dissolve in the blood, so you can get rid of it. So if this is the case, it's beyond the capacity of the liver, so the bilirubin will be unconjugated. How about if you have a problem with the liver? The liver will take the remnants of the bilirubin, it will conjugate part of it, but if the liver is sick, which is called hepatic part, if the liver is sick, or intrahepatic, if it is sick, it will conjugate part and not conjugate the other part. So this, you will see a combination of conjugated and unconjugated. What if your blood is okay, your liver is okay, everything is fine, you conjugated, but here you have an obstruction for some reason. This is obstructed. Break down the blood, bilirubin, go to the liver, conjugate, everything is fine. But you have post-hepatic problem. It doesn't leave. So it go back to the liver, reflect, and now it will be conjugated. People understand this? Unconjugated, combination, conjugated. And prehepatic is usually hemolysis. Hepatic is a liver disease, specifically hepatitis and cirrhosis. Post-hepatic is something that's blocking the pathway like tumor and cholelithiasis. And I talked about being conjugated or unconjugated. Did you understand this part? Unconjugated, mix, conjugated. Hepatitis. Hepatitis is inflammation of the liver. It can be infection or not. If it is coming from alcoholic, it's fatty liver. Okay, this is very specific. If you have alcoholic hepatitis, what you're going to see? Give me an ultrasound to the liver. Give me a CT, and I will see that the CT contain a lot of fatty liver. It can be viral. It can be chemical. Viral hepatitis, it can be any one of these, A, B, C, D, E. What do we need to know about each one of those? A, it's RNA. That's number 1. Number 2, fecal-oral route. Means hand having some feces somehow, or it come from water, food, whatever the reason is, and go to your mouth. So it goes from food or drink. This is called the fecal-oral route. And an exception to that is the anal intercourse, because it can take from the anus to the circulator round and go somehow to the mouth. So this is an exception, but this is the most common route. What do we need to know about hepatitis A? Besides it come from the food or drink, you will not become carrier, you will not become chronic, you will not have cancer because of that. This is very important to distinguish. Are we following? You will not become carrier. There is no carrier, no chronic, no cancer. It's not precancerous. Hepatitis B. It's a double-strand DNA, different type. Okay? Most of the time, you can be asymptomatic and you go to carrier, which was not the case with A. Chronic inflammation, how is it transmitted? Let me say this, which is in common just to help you memorize. Type A, we talked about it, right? Food, not chronic, not carrier, no cancer. Okay? B and C have the following in common. Mode of transmission, blood sexual intercourse, both of them. Both of them can become carrier. Both of them can become chronic. Both of them can cause cancer. Did you get what's common between those? This is important to know. Okay? Both of them, in all cases. What kind of cancer? Hepatocellular carcinoma. But hepatitis C is an RNA, so the virus itself is different. But otherwise, it's the same. Are we following? Both of them have this in common. How about D? D is incomplete virus, and only if you have hepatitis B, then you can get D. So can I give you hepatitis D and do something for you? Nothing. So it comes on top of B. How about E? Very close to A. Food or drink. Same thing, no carrier, and so on. Now, if you have hepatitis, you will not jump into jaundice. You have hepatitis, let me see your eyes, it's yellow. No, that's not right. This is something that will occur later on. So before you have the yellow, this is called pre-icteric. By the way, icterus means jaundice or yellowish discoloration. Pre means before. Are we following? Pre-icterus, before your body become yellow. You just have some anorexia, nausea, some pain, and that stuff. And this is what happened in the beginning. Not you don't come to me all the time, you have yellowish discoloration. This is late. This is later on. Okay? So this is pre-icteric, I have some nausea, some fatigue. Accidentally, I do sonar, your liver looks a little bit bigger, there is something wrong here. Give me some blood sample, I find that you have it. Accidentally. You didn't have the yellowish yet. The next state is icteric. Icterus means jaundice. Now we have the jaundice. Now you have the jaundice. Now the liver become bigger. Now the enzymes become more. I get a blood sample, I see more liver enzymes. Where is the liver enzymes coming from? The liver enzymes are supposed to be within the cells. But because of this, you're breaking down the cells. The enzymes leaking and go to the blood. So if I take a blood sample, I can see a lot of these enzymes. And because of the accumulation of the bile salt, the bilirubin is irritant. So you'll see those patients like scratching like this, okay? Because of this accumulated bilirubin. The last stage is post-icteric. I had jaundice, now started to disappear. But it's still hepatitis. Signs will go down, but this person will become weak until you get a treatment or something. Look at this. I think you have hepatitis B. Give me a blood sample. Yes, I see the virus and I see the antibodies. You are having active hepatitis right now. Pre-icteric, icteric, post-icteric, later on. The jaundice start to disappear. Give me a blood sample. You still have the antigen. You still have the virus. It means you became chronic. Do you understand this? It should go down. If it doesn't go down, change and become chronic now. Chronic hepatitis. Toxic hepatitis, this is another condition that come from hepatotoxics, like some drugs and some chemicals. Toxins, something toxin to the liver, drugs and chemicals, something like carbon tetrachloride and ethanol and that stuff. Like if somebody is drinking ethanol, somehow, this is toxic, hepatotoxic. Cirrhosis is a progressive destruction and fibrosis of the liver. Both of them. Destruction, necrosis, followed by fibrosis. It can come from alcoholic, drinking a lot of alcohol. It comes from biliary cirrhosis. The bile is not leaving. It go back, return, irritate the liver. It can be the post-icteric cirrhosis, which is the last stage of hepatitis. It can lead to cirrhosis and can be metabolic. In all cases, at the beginning, it's asymptomatic. until you start to get the symptoms. Alcoholic hepatitis, I mentioned that in the beginning. The first stage is fatty liver, and then alcoholic hepatitis. What do you lose with cirrhosis? You lose all of those. These are all the functions of the liver. You lose the function of the liver. Producing bile, taking care of the food, metabolic function, blood clotting. You don't do blood clotting. You do not convert ammonia to urea. You do not store glycogen and so on. But this is, I want to stress on this one. One of the functions of the liver is detoxification. Did we mention that? Detoxify. One of the things that you're supposed to detoxify is ammonia. Ammonia is a very toxic product of the protein breakdown, toxic and not soluble. The liver take it, make it less toxin and soluble, so you can get rid of it in the urine, which form urea. If the liver is bad, you do not convert ammonia to urea. Urea is less toxic. This is how you get rid of it. Urea go to the urine. What if you don't do that? Because of the liver, ammonia will accumulate. If this ammonia accumulates enough, it will go to the brain, causing something called encephalopathy. Did you understand the rationale? Encephalopathy.
That's what happens to alcoholics.
Alcoholics they go to the same situation. The liver is bad, do not convert ammonia, ammonia increase, go to the brain and causing encephalopathy. And what will happen to you? Cirrhosis, fibrosis will lead to obstructive jaundice, portal hypertension, varices, and so on. Esophageal varices will occur because of increase of the hydrostatic pressure of the blood. Cirrhosis can be also, or hepatitis and cirrhosis can be also followed by ascites. What's ascites? Accumulation of fluid in the peritoneal cavity. Here is encephalopathy that I talked about. This, because of ammonia accumulating, building up. Treatment is all supportive unless liver transplant. Liver cancer, the most common is hepatocellular carcinoma. It can be primary, and sometimes it's secondary. You know what's the most common location for the liver cancer, the cancer to go to the liver? Colon. Come from the colon, large intestine, and go to the liver through the hepatic portal system. Acute pancreatitis, acute inflammation of the pancreas. The most frequent reason is the enzymes that are supposed to leave the pancreas doesn't leave it. Start to erode in the pancreas itself. Or to digest the pancreas itself. And it can cause hypovolemia and syncope because of that. The most common cause of acute pancreatitis is gallstone and alcohol. Gallstone and alcohol. This is the most frequent cause of acute pancreatitis. These stones or the alcohol is going to close the exit for the pancreatic enzymes and start to auto-digest the pancreas itself. If it is acute, it will be pain, which is the most important of all, pain, and can be followed by shock, which is hypovolemia. Diagnosis, measure the enzymes and do a CT scan or something, and treatment. Cancer of the pancreas is usually adenocarcinoma. This is the most common form. And if cancer occurs in the head of the pancreas, and if it goes to the common bile duct or the pancreatic duct, it can be discovered early. You know what I mean? Like this is in the cancer head and go to the to the common bile duct earlier. Closing it, you start to have jaundice. We start to look and we see a cancer early. Okay, so this is, some people, if they are fortunate enough, the cancer in the early stages is very close to the duct, occluding it. So give us an alarm. There is something happening earlier there. Lower esophageal problems. Celiac disease is basically a malabsorption syndrome, genetic problem. They have gluten problem. Gluten irritate and you lose the villi. Are we familiar with the gluten-free diet? Yes. So you have an overreaction to gluten, breaking down your villi, having malabsorption, atrophy of the villi, malabsorption and malnutrition. So treatment is gluten-free diet. IBDs, chronic IBDs. There are two diseases that we need to know here. And this is good enough to know. What are the two conditions? It's inflammatory bowel disease. Inflammation of the of the intestine. Crohn's versus ulcerative colitis. Region, location, Crohn's disease in the ileum, ulcerative colitis from the name, colitis, it is in the colon. Okay? Distribution, this thick, the whole wall, this is usually the mucosa only. The stool here is loose. Look at this one here. Very characteristic. This. Frequent watering with blood and mucus. If you see this, it's ulcerative colitis. This is how important this is. Look at the stool. If you see it watery, blood and mucus, it's ulcerative colitis. Sometimes fissure and fistula occur with Crohn's disease. It doesn't happen with ulcerative colitis. Obstruction, the same thing. Malabsorption is the same thing. So Crohn's disease have a lot more important consequences than ulcerative colitis. But the unique thing about ulcerative colitis is blood and mucus in the stool. So this is enough to know for both of them. Treatment, glucocorticoid, sulfasalazine. As I mentioned before, treatment is not the most important thing, okay? Pathophysiology. The pathology itself is more important. Irritable bowel syndrome, this is a chronic irritation. This person is having stress or something and he's having continuous colics. The bowel or the digestive tract is irritated commonly, leading to a lot of motility, increased motility and secretions. So what those people will have? Lower abdominal pain, diarrhea, constipation, bloating. These are the manifestations of this problem. Next is appendicitis. Appendicitis is inflammation of what? Appendix. What's the most common reason? Again, most common. Here is the appendix. If you close the outlet of the appendix, it will accumulate. Secretions will accumulate in here. It will get infected. Distend, appendicitis. It can rupture. Okay? Did you understand what's the reason? Obstruction of the lumen. If you obstruct the lumen, this will be followed by infection. If you don't obstruct it, if it's like this, secretions go out all the time, no problem. If you close it, this is the problem. And it will lead to inflammation. And here's what's characteristic about appendicitis. Look at this. I'm having pain around my umbilicus here, vague, first, now it's here. And I can point to it with my finger. Means it was just general irritation, visceral pain, and now it's localized here. Classic, that's it. Even if you're not a doctor. I have a pain here, now it's here, that's it. Appendicitis. Now it's become somatic pain. The problem with appendicitis is if you leave it alone, okay, it can distend enough, can rupture, open, releasing the contents to the peritoneum, causing peritonitis again. Any part of the digestive tract, if it open, leaks to the peritoneum, causing peritonitis. Generalized pain and tenderness. So if the bacteria and toxins started to leak out of the appendix, it can irritate, causing bacterial peritonitis. It can cause abscess as well as one of the consequences. What's the treatment? Remove it. Remove it. If it is becoming chronic or causing abscess or something, before it actually rupture. If the pain become localized, where do you find it? At the beginning, it's periumbilical, right? Vague. Later on, it will become localized. Where? Right lower. Okay? And you can point out with your finger. Can you tell me exactly where it is? It's right here. At the beginning, here. Can you point out to it? It's somewhere around here. Now, a couple of hours later, it's here specifically. Appendicitis. There are no other scenarios. Diverticular disease. All what we need to know here is diverticular disease is, here is the intestine, it will start to make something like this, outpouching. Okay? If this inflamed, you call it diverticulitis. Diverticulitis. And diverticulitis is inflammation of the diverticula. Look at this clue here. Left lower quadrant pain, diverticulitis. See how specific? Yes, that's how specific it is. Diverticulitis, you have diverticulum that's got inflamed, and the pain will be localized. Where specifically? Pain and cramp and tenderness. Where? Left lower quadrant. Colorectal cancer is a cancer of the colon and rectum, and usually start as adenomatous polyps. Do you guys remember when I said at the age of 50 you need to do colonoscopy? Because of this. Adenomatous polyp. This type of polyp specifically is precancerous. There is a familial tendency, which is the polyposis. If somebody is having ulcerative colitis that I mentioned before, if it is chronic and not treated, it can be precancerous. Genetic and environmental factors can play a role, and if you take a lot of fibers, this is good. This is good for prevention of this type of cancer. There will be an alternation between diarrhea and constipation, and there will be bleeding, occult bleeding specifically, hiding bleeding, cancer. Surgical removal, radiotherapy, anything else is fine. Intestinal or intestinal obstruction. This obstruction can be neurological or mechanical. In all cases, if you have obstruction, here's what's going to happen. The rest of your digestive tract will contract, trying to push and open the obstructed part. So this will be continuous colicky pain. And this is unique for this. Okay? Proximal to it, severe, steady abdominal pain. You have obstruction and your digestive tract will not stay silent. It will start to contract, trying to open what's closed, the obstruction. Steady, severe pain, trying to get rid of it. So the abdomen will become distended, you start to lose some fluid and electrolytes. But if you leave it alone and this is obstructed, it can become gangrenous because you are jeopardizing or you are decreasing the blood supply to that area. Bacteria will come and it can actually cause infection, accumulation, lead to necrosis. If this obstruction lead to perforation, as I mentioned so many times before, anytime you have any type of perforation, it go to the peritoneum, causing peritonitis. Different types of obstruction. One of them is functional, and this is called paralytic areas. Functional. It's not mechanical. It's the nervous system is having a problem. Like after surgery, do you know that somebody's having surgery? I didn't go to the bathroom for 1 day, 2 days after surgery. I don't know what's happening. Paralytic ileus. This is something temporary after the surgery. It can be spinal shock, it can be any types of infection, it can lead to hypovolemia. But if it is mechanically, it can be due to any reason, and this is important. It can be adhesions, strictures. It can be intussusception, volvulus, and Hirschsprung disease. What is this? Intussusception is this. Look. This is your intestine. Part will be telescopically get into the other part. Do you understand this? Goes like this and enter yourself. Enter itself inside. Okay? This is called intussusception. It intussuscepts itself. Mean telescopic proximal part get itself inside the proximal part. This is called intussusception. Volvulus is like this. This is the intestine. Okay, and it will start to go like this. Twisting. Okay? Both of those can lead to obstruction. So this is twisting, and the problem with twisting is if you do this, you can cut the blood supply to this part, leading to necrosis and gangrene. Intussusception, same thing, and that's why it has to be treated as fast as possible. Hirschsprung disease is a congenital problem with the parasympathetic nervous system. Low motility, Hirschsprung disease. So we talked about paralytic ileus. If the intestine is obstructed, obviously you will have vomiting, abdominal obstruction. This is a medical emergency, by the way. Intestinal obstruction is a medical emergency. Rush to the ER because gangrene can occur, right? Obstruction of the large intestine is rare. Peritonitis, I talked about this. It can be chemical spilling, or it can be infectious. Bacterial can come from the intestine, rupture, appendix, intestinal obstruction or gangrene can cause it. But PID is another condition, especially in females. If you have pelvic inflammatory disease, you'll have infection like in the fallopian tube, for example. This infection can escape from the fallopian tube and go out to the peritoneal cavity, infecting the peritoneum. Did you get this part? Females, do we know that the fallopian tube is open? It's open to the peritoneal cavity. So this is another condition. And if peritonitis, there will be sudden severe generalized abdominal pain. Okay? And this is the last thing here.